Right. I think we all know there's so many classifications in orthopedics, fractures, classifications, different parts of the body. You've got 20 classifications of fracture of the shoulder and so on and so forth. But it's not the problem if it means something to us that can help our clinical practice. So the ideal classification should be able to serve a few functions. Of course, the first one is for ease of communication. So we have the same language and we know what we're talking about. It should be very easy to remember, and the classification should be reliable between observers. Hopefully, we can also understand the etiology or the pathomechanism of that particular pathology and help us in prognosticating the outcome. So if type 1 is going to end up like this, type 2 is going to end up like this, etc. And hopefully also it can help us, guide us in the treatment of or the management of that particular disease. So in this case of adolescent idiopathic scoliosis, we would like to know which curve should be treated, which curve should be fused, and if so, what are the segments or levels to be fused, etc. Now, there are a number of classifications that are commonly used nowadays. For those who have been in the practice for longer, you would be mostly using the King's classification, I'm sure. But more in the last 15, 20 years, everybody is starting to use the Lanke's classification. And of course, it's now probably the most common classification being used. When you ask our residents, what's the classification? What about the scoliosis? Lanke. Everything is Lanke. Okay, well, that's fine. I mean, Lanke is a good friend of ours. So we see how good or how bad is this classification. There are two other classifications that are available, but I don't think we're using them. One is the classification derived from Beijing, from a very large cohort of subjects or patients, and then Herbert Labelle's classification based on the 3D deformity in 2006. So which one of these classifications satisfy the criteria that we mentioned in the first slide? Oh, by the way, King was a fellow, correct me if I'm wrong, George and John. King was actually a fellow of John Moe at the time when he did a fellowship with Moe. So he actually developed the King's classification. Is that correct? Howard King, yes. And then obviously we know Larry Lanke. Professor Chiu is the chairman from the Peking University, Peking Union Medical College in Beijing, and Herbert Labelle is from onshore in Canada. Now, the King's classification was actually first reported in the 1980s, and they did it through a retrospective series of over 400 patients, and they classified mainly from a pattern recognition. So we recognize the pattern of the deformity particularly in the coronal plane. So we look at the frontal view or the PA or AP view of the spine, and you draw the central sacral line through the midpoint of the S1, and then you erect this line and decide whether the curve is deviating from this central sacral line. And later on, it was modified by Ferguson, opposed to the stable zone concept by Ferguson, where you erect two vertical lines on the S1, the L5-S1 facet joints. So it's that zone in between is called the stable zone. And in this classification, it determines whether the curve is a true curve or not a true curve, a compensatory curve, depending also on the flexibility of the curve on the supine radiograph. So as I was trying to ascertain earlier, how many of us are actually doing scoliosis day in, day out, and then you should be quite familiar with the classification or King's classification. When the curve crosses, when a spinal deformity crosses the sacral line, then it's called a curve. Okay, that's simplistic enough. And the type 1 curve would be primarily a lumbar major curve, a lumbar curve. And then a type 2 curve will be a thoracic curve together with a lumbar curve, usually around the same size. And the recommendation for the treatment by this King's classification is if you have a lumbar curve, you always fuse the lumbar curve in a type 1, but sometimes most of the time you may want to include your thoracic compensatory curve. In a type 2, you fuse both if in doubt, but preferably you can fuse only the thoracic curve. So this is what later on we'll call this the selective thoracic fusion. But at the time when King made this classification, is that whenever in doubt, fuse also the lumbar curve. The type 3 is a relatively more simple, it's a thoracic curve, and the lumbar curve is more of a compensatory curve. So you only need to address or fuse the thoracic curve and leave the lumbar curve behind. Type 4 is a long curve that goes right down to L4. And so in this case, you have to fuse the primary curve, and this will mean that you have to fuse long, usually in the L4, if not L3 or L4. Type 5, the King's classification is your double thoracic curve. You have an upper thoracic or proximal thoracic curve. We call it PTC nowadays. A proximal thoracic curve and another major thoracic curve. The lumbar part is actually more of a compensatory curve. Now the specific problem with this one is that because of the proximal thoracic curve, the T1 will be tilted, and most of the time you will end up with a shoulder imbalance. So if you fuse the wrong levels or you chose the wrong levels to fuse, then you may end up aggravating the shoulder imbalance after the surgery. Now the limitations of the King's classification is primarily it only addresses the coronal deformity. It only addresses one plane deformity. And it does not have, strictly speaking, it does not cover the thoracolumbar curve where the apex is at T12 or L1. So you can remember just now we have a double curve, we have a thoracic curve, but it's actually no true thoracolumbar junction, thoracolumbar curve. And it does not also address the possibility of a triple curve where you have an upper thoracic, main thoracic, and a lumbar. So it is not present in that classification. Now, to differentiate between the type 1 and the type 2 as to which one is larger, the lumbar larger or the thoracic is larger, they rely on the flexibility of the curve on using a bending film. We'll come back to that a little later because the way you do your bending test will determine how much will the curve go unbent. So if you keep that at the back of your mind, that will affect your classification. That will affect which curve will be allocated into which type. So the problem is the term of structural, which I think has persisted into the Lanke's classification. I'll expand a little bit more on that later on. And it does not, this King's classification puts very little emphasis or even did not mention anything about the sagittal alignment. So we've said it's a coronal pattern recognition. Of course, at that time, when the King's classification is mainly applied to the traditional, relatively simple instrumentation that we use for surgeries, the Harrington instrumentation, where you only put one fixation point cranially, one fixation point caudally, and you distract the spine in between. So you probably ignore the sagittal alignment, and a lot of these patients end up with a flat back because of this distraction. Okay? But because you have only two fixation points, the advantage is that the spine will balance itself. You will actually have less problem with the so-called shoulder tilt, etc. But nevertheless, it's a relatively simple classification, and it can serve as a very good communication tool. And as soon as I tell you there's a King 1, King 2, King 3, you know what we're talking about. And your resident calls you in the middle of the night, you know what he is talking about. And have relatively simple guideline for surgery. You fuse one level above, one level below your primary curve. So that's a very easy formula for people to remember. And the major problem is does not consider the sagittal alignment. Now then, the Lanke's classification makes significant improvement in that sense. It was first reported in 2001, and they divide the curves into the three zones, the proximal thoracic, the main thoracic, and then the thoracolumbar and the lumbar. So at this point, the thoracolumbars are actually grouped together with the lumbar curves. The largest curve among the three zones will be the major curve, and the other two, he would call it the minors. So the curve type, again, is a coronal pattern recognition. Group them into type 1 and type 6. And put the two classifications together between the Lanke and the King, you will know which one actually correspond to which one. In the lumbar spine, it was further grouped under the modifier A, B, and C, showing how big is the curve. If the curve is still within that central sacral line, it's an A. If it touches the inside of the central sacral line, is B, and if it goes away from the central sacral line, is C. So basically, ABC tells you how big is the lumbar curve. Okay, so the more it stands away from the central sacral line, the bigger is the curve. And the other sagittal thoracic modifier is to look at the sagittal profile, whether it's normal kyphotic, hypokyphotic, or hyperkyphotic. It's not easy for you to remember this chart unless you're using it day in and day out. But basically, you can see the major curves are actually 1, 2, 3, 4 are the thoracic major. Right? 5 and 6 are the lumbar majors. And then the others are structural. or non-structural. Now that's where the problem is. When you look at the further definition of structural, a structural curve, oh sorry, this is just to correspond it with the King's classification. Type 1 Lenke is equivalent to the King 3, etc., etc. So if you spend some time working on this, you understand that. And the recommendation for surgery or treatment is that you fuse all the major curves. So you would see from that earlier chart, all those with the bracket called major, 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 fuse all of them. That's the first step. And the next step is to fuse the structural minors. Now the definition of structural minors, we'll come to that later. And then you fuse the larger curves. If you have the curve that's deviating further away from this central sago line, meaning the C's, you should consider fusing them. So that's a relatively simple concept to follow. But it doesn't really give you a specific recommendation on which level. Say, should that stop at L3 or stop at L4? But it just tells you, okay, the lumbar curve needs to be fused. So they still give you the flexibility of, so that our next speaker can tell you how to select the levels of fusion. Now, if you look back into the development of the Lenke's classification, it was actually derived from a very small sample of subjects, only 27 cases. Of course, now everybody's using it. You've got millions of patients being put on that classification. But when it was first described, it actually was derived from a very small group of subjects. And it does not have the equivalent of the King 4. Remember, the King 4 classification is a long curve that goes down to L4, and it doesn't. You don't find that in the Lenke's classification. And there's also a no King 2, where the thoracic curve is exactly the same size as the lumbar curve. Right? Remember, in the Lenke's classification, you can have a larger lumbar and a smaller thoracic, and a larger thoracic and a smaller lumbar, and so on. And there's no specific group that has an equal thoracic and lumbar. And the Lenke 3 treatment for Lenke 3 and Lenke 6 is the same. It doesn't matter whether it's a 3 or 6, you'll fuse both curves. So it doesn't really pinpoint specifically the difference in the management. So as I mentioned, it only guides the region to be fused, but it does not give you the specific levels to be fused. Now, I personally find this the most irritating thing for me, because our teaching of what a structural curve versus a compensatory or postural curve is that there's no rotation in that part of the spine. If I stand like that, I've got a postural scoliosis. This is not a true structural scoliosis. If you ask me to stand straight, I can stand straight. This is a postural or a compensatory curve. A structural curve is a curve that has a structural deformity where there's rotation. But in the Lenke's classification, they use flexibility as a criteria for defining structuralism, if there's such a word of structuralism. And they use a 25-degree as a cutoff line on the bending film. So it depends on how hard you bend. If you bend harder, the curve becomes less than 25. You bend less hard, it becomes 26. And then by definition, that becomes a structural, Lenke's structural curve. And you can then consequentially, because it's a structural curve, you're advised to have that fused. Right, so you can see the consequence of the definition or how you can derive as a so-called a structural curve. So the structural versus non-structural is different than what we have been taught conventionally, where a structural curve is one that has a three-dimensional rotational element in it. And flexibility on your bending film should not be confused with the word structuralism. So this is maybe you need a little time to digest what I'm trying to say. And then the fusion, the selective fusion of the two curves is different from what the original recommendation is, where you can do selective fusion of one and not the other. And theoretically, they recommend, Lenke's classification recommend anything that is large and stiff, then you should fuse. But subsequently, there are more and more papers coming out that you do not necessarily have to fuse the larger compensatory and the larger structural, right? So more and more evidence is coming out that this C modifier may or may not be that significant. This concept of flexibility may or may not be relevant in this classification. And as I said, some more and more evidence, even from the Lenke group themselves, sort of start to challenge the original recommendation of fusing the larger structurals and the larger type C curves. Now, this group classification, I'm personally involved with that, so just want a couple of words. In China, they try to do this classification from a larger number of patients. Now, it's still not that large. It's from 427 instead of 27. And we use again, you use the same pattern recognition. But this is so complicated. I would not advise you to read this article. I would not advise you to use it. It's too complicated because it gives you subgroups. So after the first 2 tiers, you will not remember what you were doing. But the advantage of this grouping is that it starts to address the rotational element. It starts to address the rotation component of the curve here, which is not exactly mentioned or emphasized in the Lanke's classification. So the good thing about this, the bad thing about this is too complicated to be used clinically. But the concept is good. It starts to address rotation and sagittal deformity, which were not addressed in the previous ones. Okay. Now then, if we want to consider the deformity in a 3-dimensional way, so the best one would actually be the Herbert Lebel's concept of how you look at the 3-dimensional deformity in total. You're not looking at only a coronal projection of the 3-dimensional deformity. You're not looking at the sagittal projection on an X-ray. You're looking at the patient from the top or from the bottom. You look at how much each of the vertebral body is rotated. And they come up with very complex classifications or complex description of how each vertebral body rotates, and obviously consequentially how the ribs are being carried along and then giving you the rib hump clinically. But the classification is a little bit too complicated for clinical use for the time being. And for research purposes, it's good because now then we know how much derotation of the spine you can get after your surgical correction. You would have heard the various development in the instrumentation claims that you can actually derotate the vertebral bodies better than the previous Harrington rods or even a simple pedicle screw fixation. So we are waiting for Herbert Lebel and his group to come up with something that's probably, hopefully, more clinically useful than in the clinics. So if you compare all these classifications available, there's some pros and cons of each of these. But you can see the development has changed gradually from a coronal pattern recognition to a coronal sagittal, and now it's a coronal sagittal and axial deformity. But having said all that, there are still pattern recognition. Now, coming back to the point of flexibility, as I said earlier, the flexibility on the bending film decides whether it's a structural or non-structural. Structural or non-structural decides whether you should fuse it, and so on and so forth. So how you do the flexibility testing is very important. Right from the days of the King's classification, you would just ask the patient to bend to the side, and you take an X-ray. Right? So this is patient's sort of self-effort, bending the spine for you so that you can get an X-ray. And you can immediately understand this is very variable. If the patient bends very hard, they will get straighter. If the patient is very fat, he simply cannot bend because the soft tissues are butting already. So that affects your classification, and that classification affects your treatment. So it's not logical. We have, I have actually started this, what we call the fulcrum bending radial rod back in the 1990s. We have found that this is a very reproducible method. I'm not saying it's the best, but it's very reproducible. By putting a fulcrum under the apical rib. So if you look at the thoracic spine, you find which is the apical vertebra, trace that rib to the mid-axillary line, and put a fulcrum under that particular rib. And then you lie the patient over that bolster, and so lift up the shoulder, lift up the pelvis from the X-ray table, and take a cross-table PA or AP X-ray. Now the patient's body weight will be completely hinged over this fulcrum, and you get a very reproducible flexibility or correctability. The word is correctability. It tells us how much the spine can be corrected safely without neurological risk. So if the curve unbent from 69-degree curve in an active bending, it went down to 25. But by definition, this is a structural curve in Lanke's classification. But if I use the fulcrum bending, you can see the same curve actually bends out to 16. So should we still call it a structural curve? Should we still treat this like a structural curve and fuse it, and so on and so forth? I'm not going to go into the details of that. So we have all these classifications. Which one of these would satisfy the criteria that we set out to satisfy? I would say none, not yet. We cannot prognosticate which curve is going to progress. We cannot tell us exactly which level is the best way to fuse. And we do not know whether a type 1 curve has got the same problem as a type 5, type 6 curve. Okay, so that will only come if we could understand the etiology of AIS. We don't even know what is the cause of AIS, and that's why we call it idiopathic. A thoracic curve may be different than a lumbar curve, and they may have different prognosis right from day one. So how do we know that? The only thing we can know is when we crack the code and find out what's the cause of idiopathic scoliosis. And the classification will then be based on the genetic etiology, and we know for sure which curve is going to progress and which one is not. So how useful are these classifications available now? It's as useful as you want it to be. So you use it as a communication tool, but then see what you exactly want to do. If you want to assess rotation, you better find a classification that can address that problem. If you just want to make the patient happy with a PA X-ray, the King's classification or Harrington rod is equally good. So it depends on what you want. Thank you very much.